the name, so it was personal, and really trying to emphasize areas where we had identified problems. So it was kind of pushing certain areas where we knew there were sometimes performance issues. So the idea was that this would all increase community health worker performance and motivation, which eventually then would lead to better, more appropriate treatment of sick children. So that was kind of the theory of change we expected to see. So using this kind of new framework that is in your pack, which I think is a really nice overview of how iCCM and community health workers kind of link into the health system. So just to give you an idea, whereas our interventions were really designed to really change or improve appropriate treatment, there were other spin-off effects that we not only hypothesized, but that we're actually now seeing results of. One, for example, being in Mozambique, the phones we use are slightly more advanced. So there are smartphones which not only have the job aid programmed to walk them through each step of the consultation process, but we built in also educational messages so that they can play the messages to the caregivers in Portuguese and educate the caregivers as they go along on the importance of prevention and promotion activities. So what we're seeing and what we're expecting to see more in our process evaluation is how that can establish a better patient-provider relationship with more effective counseling, which hopefully also will increase recognition of symptoms in the household and improve care seeking, just by the mere fact that they can now see pictures of children with and videos, program videos, children with testing drawings and danger signs, etc. And also, hopefully, improve health prevention behavior. We've spoken to a number of caregivers who find that the fact that now there's a voice on the phone telling them that they need to sleep under bed nets every night can actually be quite effective. Other things is around the fact that the data is now coming in much more timely and much more complete. Not only does that give the program planners and so on access to this data, but also the supervisors who get this data in an aggregated report for each individual, how they can now use this to really target supervision and identify the community health workers who need the most support, and also the areas where they need most support, because we know these supervisors are very busy in their health facilities. They do not have time to go out on a monthly basis to see all the community health workers. So by using the phone, they can now pull out those who have the biggest problems and make sure that they get the support that they need. The data is also used for better forecasting of medicines, but also to redistribute medicines between community health workers. There's often kind of a disproportionate stocks out there in the communities, and how the health facility supervisor can now kind of move medicines between the community health workers. And finally, just having access to this data can guide response actions. If we see that there is a lot of malaria real-time happening in one area, then that obviously can spark an action to go out and investigate. So the implementation area in Mozambique, we're doing a randomized control trial where we're working in Nampula province, and we have randomly allocated 6 of the districts to the intervention arm and 6 to the control arm. And in the intervention arm, we have 132 community health workers and 47 health facility supervisors trained and provided with funds, and they will be evaluated. Impact evaluation will take place now after 12 months, which is later this year. And we're currently doing the process evaluation. So in Uganda, where the scope is very different because we're working in the same geographical area, kind of size area, there's many more subunits here. So we have randomly allocated 13 sub-counties to each of the 2 interventions. We have a community engagement intervention and the M-Health intervention, and also control arm. But here we have almost 1,300 community health workers who are receiving phones and trained in the mobile phone application. And we're using simpler phones here, Java-enabled Nokias. So some of the lessons learned is that from the process evaluation data that's now coming in, we've done a number of qualitative interviews and in-depth interviews with community health workers and their supervisors, is that the data submission component is, the feedback was extremely motivating, not only because they feel that they're now, someone is actually seeing them in the work that they're doing, but the feedback message that come back can be used to show other community members the work that they're doing. It's, one of our community health workers talking to a motorcycle taxi driver, showing him his message. Also the communication, the fact that they can now communicate freely with their peers and with their supervisors was extremely motivating and increased the linkages. Not only referrals, we find that we have many stories of how the fact that a mother or a caregiver observes the community health worker making that phone call and making the connection with the health facility before referral really increases the referral compliance. There's also referral between community health workers. So if they are out of one of the medicines, they can easily call up the neighbor community health workers and check whether the mother or the father can go there instead. There's much more efficient kind of restocking of medicines, because instead of having to go every day to the health facility to find out if there's any new medicines to pick up, they just call up in advance. And the peer support, the fact that they can just talk to each other, the community health workers talk to each other to find out how others have solved issues around anything really, has been extremely motivating, and they feel that it's increasing their performance. And what we found as, again, an unexpected positive effect was that the solar charges we have given them, really only just to make sure that they could charge their phones, the light that provides is now enabling them to treat children much later in the days and at night. And also many community health workers have set up kind of reading clubs for school children who come to their houses to study and do their homework, and that has also put them at a much higher level in the community. They're now seen as very important people. And both in Uganda and Mozambique, we programmed the phones with a respiratory rate timer that basically removes the need for the community health workers to have to count the respiratory rate. They only have to press the search button every time they see a breath. And for many community health workers, they mentioned that that was one of the most important functions of the whole mobile phone package, because now finally they can show the results to the caregiver and explain why they don't need to give antibiotics. There were, of course, quite a number of barriers. The system functionality, we've had quite a lot of bugs, especially in Uganda with the system, and how we had to go back and reprogram the phones a couple of times. To work with the mobile phone operators isn't always easy, and to have timely and automated kind of reactivation of data bundles and phone access is not as smooth as you would think. Patchy network coverage, and that's a picture of one of our community health workers sitting on top of an anthill trying to sense data. While Uganda has fairly good coverage, Mozambique is not as good off. It's improving every day though, so hopefully not by long it should be better. Equipment breakdown is another issue. We have had not too many phones breaking down, but probably I would say 5 to 10 phones out of 200 have broken, and especially the solar chargers. And also teaching old people who don't have good eyesight has been a challenge, because they simply can't see what's says on the screen. I think I'm running out of time, so I'm just going to show you a little bit of what kind of data we're now getting. This is data from Mozambique from 6 months of data that's been submitted. And because we get patient-specific data, it's not aggregated because they submit the data for each patient. Seeing from these 132 applications who now have the phone, they've sent in 36,000 patient forms. What we found, which was quite surprising, is the majority of the patients seen are adults. But if we look at the under 5s, there were about 14,000 children under 5 seen. 9% had pneumonia, 16% were diagnosed with diarrhea, and 61% had confirmed malaria after RDT results. And we also get data on that we can track malaria positivity rates over time. So this is just to show that within only 350 kilometers distance, there's quite a big difference in the proportion of children with fever who have positive malaria tests. So my last slide is really around how this can potentially be expanded and how we think in Mozambique we're looking at ways of perhaps expanding and strengthening the health system more broadly. So looking at incorporating modules in this package for other conditions like pregnant women, incorporating birth and death registration in these modules, and perhaps using audits like verbal and social autopsy to investigate reported deaths. Immunization, I mean, we're already, as part of the iCCM, already collecting completeness of immunization, so perhaps having a follow-up of children who don't have complete immunizations and linking that to systems. Building also health facility reports, because we have quite nice and complete data from the community level, but still the data that we get from health facilities isn't necessarily that complete. So also building in a module for their supervisors' phones to report their data would be, I think, we think a good idea. Having a more complete commodity tracking system. At the moment, we're discussing again the Demaki, who's the program developer behind this system, to see if we can incorporate C-stock, which has been tested in other settings, and make it more complete stock tracking. Because we now have the information on performance and performance indicators for all our PESH and community health workers and the health facilities, then it could be that data could potentially be used for better performance monitoring and potentially even performance-based incentives if the country was choosing to go down that route. And also, of course, improve planning of services at high level to make sure that budgets are made available and using accurate information. So my last conclusions are that we are seeing that mHealth is already beginning to transform the health systems where it's delivered, and it's also what we can see from the literature, and there are some concrete benefits coming out. But to maximize impact of these programs, these solutions should and need to be holistic. It won't help just to have mHealth applications that only track commodities or only report a few indicators of patient caseload. Ideally, it really should be incorporating more aspects and also integrate within the public health system to be, and the other functions to be more effective, more cost efficient. Success really depends on having a harmonized mHealth agenda in the country and working in very close collaboration, not only with national stakeholders, but with the beneficiaries. Our intervention was very much developed in collaboration with the community health workers themselves. And that mHealth approaches that do address performance and supervision in particular can be really playing an important role in containing or maintaining implementation of these programs at scale, also with where community health workers then deliver quality of care. So I'll finish with that.